About this little implantable hemodynamic monitoring. So you can actually measure when you give diuretics to the patient, you get some fluid off, are you actually improving the central hemodynamics, the pressures and flows inside the heart. It's a brand new thing, and the argument was, should it be used more, should it not be used more, and so forth. The side in favor of using it said, look, this is brand new and we really need a lot more experience, but we can really regulate the patients a lot tighter if we have this information than if all we're using is our stethoscope and the echo. And the argument against it was, most of the patients that need this are so sick that they're not going to do well regardless of what you do. So, and both sides there's probably a lot of truth on both sides. It's like anything that's new, you know, Adam, I would say probably you want to see 2, 3, 4, 5 years of experience, and you're going to get, each year you're going to get a little better. At these meetings and the American Heart meetings and the European Society meetings, there'll be more and more studies using these things, and we'll get better at doing it. There was another clinical pharmacology session that I helped co-chair, and that was the whole question about the new anticoagulants in atrial fib. You know, there had been some concern that the ROCKET-AF, which was rivaroxaban, a factor Xa blocker trial, some of the INR machines that were given out weren't as accurate as they should have been. And so there's been some discussion in the press about that. Did that mean that the study results were wrong? And in fact, people went back and reanalyzed the data, excluding those faultier machines, and it didn't change anything. So there was a small tempest in a teapot over this, but in fact, the whole thing just disappeared after it was shown that it was fine. If you included the INR data, it pushed the thing in the wrong direction. That is, it should have made things better for warfarin, not better for rivaroxaban. So in fact, the data stands, and the other 2 10A trials, or the other 3 10A trials, were all basically in the same direction, looked like the ROCKET. So those are good drugs. The only issue is expense. And I always tell the patients, check with your pharmacist or your insurance before you go to the pharmacy to get this drug, because we don't want to hear that you fainted at the pharmacy. And the copays sometimes are very reasonable, $7, $8, $10, $20, $30 a month. You don't have to go get stuck with a needle, and you don't have to worry about diet and so forth, all that with warfarin. On the other hand, you know, there's some who've had very high copays and they say, no, I'll stay with warfarin. And if you're doing fine with warfarin, you've had years of warfarin and everything's going fine, then I don't push those patients to change. When we start something new, we talk to the patients about the 2 routes that they can go, and many patients would like to go the simpler route. They just take the pill. They don't have to worry about constantly testing their blood and watching, oh, I can't eat broccoli, I can't eat this or that. Yes, in fact, what we're seeing is that in the U.S., I think 60% of new prescriptions for anticoagulants are one of the new ones. And I mean, it's no surprise. It's a little bit like the same thing that happens with, you have a patient who you might be able to do angioplasty on, or you might be able to do coronary bypass. You tell the people, well, you have a choice. We can cut open your chest, or we can put a little catheter up your arm, and one, it'll take you some weeks to get better, and the other, you can go home the next day. A lot of people say, as particularly older folks, doc, I'm not ready for big, heart, chest operation. Do the best you can with angioplasty. And maybe those patients would have done better with coronary bypass, but given, their age and their other illnesses and so forth, it may be the right decision is just to do the best. I always say the enemy of good is perfect, and sometimes good is just good enough. It is, so I've been in this job for a long time, over 40 years, and from a period when there was no echo and no MRI and no angioplasty, and surgery was still, pretty risky, and now we do amazing things on all sides, in the cath lab and in the surgical suite and with the drugs, and we've seen the mortality rate falling remarkably from cardiovascular disease. And I'm not saying it's all the docs, because also the message is out there exactly because of things like this, right? People are looking at the web, people are reading the articles, they're watching what they're eating, they're exercising more, they're stopping smoking, they're doing all the things that help us to help them. And then, of course, we have much more effective medicines and surgeries and angioplasty and all that. And put it all, you put it all together. I always think of it as it's like a football team. You're supposed to have 11 guys out there, right? You don't put 5 out there and expect to win the game. So I don't know. Was it the end that was more important? Was it the quarterback? Was it the center? Well, it's the team. And it's the same thing here. It's lifestyle, it's surgery, it's angioplasty, it's drugs, it's all the developments that are coming along. And people are tuning into it.